full-time NHS consultant. I do private practice as well. I have a fairly high volume private practice doing mainly cataract and refractive surgery, do some laser refractive work as well, and have a large population of patients that are wanting more advanced lens options and better solutions than they may have available on the NHS. So I've been using the EMV for about a year. I had been using some other enhanced monofocals prior to that, and it's found a really important place within my practice, certainly with my monovision patients. I do a lot of monovision, and certainly the EMV has found its way into that very nicely, and it's made me much more confident in offering monovision to patients. So at first, I started just using it in the monovision context and for patients who are wanting a bit more spectacle freedom. And I think because of the way EMV works with the spherical aberration, I've got quite a bit of experience with presbyon LASIK as well, and it's a similar principle to that. It helps with the blend between the eyes. It gives you a bit more reading from the myopic eye. So that's where I felt most confident and most comfortable using it to begin with. But increasingly, I'm actually using it in emmetropic eyes. Patients, I had one patient recently, it was their only eye, and I had an emmetropic aim. And it's a lens that I think can be used in a huge number of patients. It's not something that is specifically for monovision. Although the name enhanced monovision, that's the branding. I think it doesn't have to just be a monovision lens. Emmetropic eyes get a really useful amount of depth of focus from the lens with very few drawbacks. It doesn't have the downsides of diffractive technology. It's a lens that you can really apply to a lot of different clinical scenarios. I haven't used it in patients who have frank macular pathology. I don't tend to use it in patients who are post-LASIK, but in other patients that don't have any other comorbidities, haven't had LASIK in the past, then I'm confident using it. It really is as my standard monofocal these days. Yeah, so I have used other so-called enhanced monofocals or monofocal plus lenses, and I must say I wasn't hugely impressed with them. They didn't do anything wrong. They didn't have any downsides necessarily, but they didn't really give anything extra. So they didn't feel as though they were worth my while either in terms of the clinical outcomes or in terms of the additional cost for patients. I couldn't really justify them. Whereas the EMV, I started off very tentatively, and I wasn't totally convinced at the start, just without having the experience with them. But the more I've used them, it really does seem to give more than you'd expect from a monofocal lens. So I've been very impressed. So I'd say be confident. There's no such thing as a free lunch, but I think the EMV is getting quite close to that. So you don't have the downsides of diffractive technology. You don't have the halos and the glare. You have very little to lose from using the EMV. It doesn't affect contrast sensitivity. It doesn't affect night vision. And I think both you as a surgeon starting off with EMV and your patients will be pleasantly surprised with how much it gives you. So, statistically speaking, about 70 or 80% of patients will, in theory, benefit from a toric lens. What I've found with the EMV so far is that it's a bit more tolerant of some residual astigmatism. So I'm happy if a patient's got less than 1 diopter of residual cylinder, I'm happy with the standard EMV. So it's probably going to be about 40 or 50% would benefit from the toric. I think that's been one of the main drawbacks, I suppose, of EMV so far, and the reason that I haven't implanted more is because a lot of patients seeking more of a refractive strategy and a strategy that's going to achieve spectacle freedom need some degree of astigmatic control. So I think now that we've got the EMV Toric, I think that's a real game changer, and I'm looking forward to using it.